Hi, my name is Elena Henson, and we're going to be talking about COPD. COPD drug therapy and includes a lot of inhalers. For your SABA inhalers, so your SABAs are your short-acting beta-2 agonist inhalers. These are most like your rescue inhalers, quick relief for those moments of breathlessness. They include your Pro Air HFA. They are mostly albuterol based. They can also be levalbuterol, like the Zopanex, in case a patient's like heart rate spikes or they just have some arrhythmias with the albuterol. So then they will be prescribed to Zopanex. Um, Next is your llama inhalers. Those are like your second kind of maintenance and kind of help a little bit extra. Those include your Incrusalipta, which is the Miclucidium, Tiotropium, which is your Spiriva Respimat. Another tiotropium, but in a DPI and a dry powder inhaler, is your Spiriva hand inhaler. And then your Tudorza is another um, the Tudorza Press Air. It's another DPI. So for dry powdered inhalers, patients need an inspiratory flow rate of, I believe, is 60 liters per minute. So basically, they kind of most of these kind of either click or pop because they have a capsule in them, and then they have to inhale really quickly. Um, and that allows that dry powder to kind of enter the lungs and kind of like sit in the lungs to kind of help. Also, they have with your dry powder inhalers, patients are required to rinse out their mouth just because sometimes that dry powder kind of settles in their tongue and then can cause thrush. Another llama inhaler is the Spiriva Respimat, and that is just a mist inhaler. And that is a tiotropium is one of the medications in those. Um, Now, if you have to have a llama and a LABA combination for a COPD patient, you have the Anoro ellipta, that is also a DPI, and the Press Air right under that, that is also a DPI. So for those as well, rinse mouth after. And then they have the Brevispa Aerosphere and the that is also a DPI. And then the Respimat is a soft mist inhaler. Another combination for medications for a COPD patient can include um, the Advair Discus, Respimats, just a regular inhaler. Um, Trilogy has three medications, so it has your LAMA, your LABA. I think it has a SABA, a LAMA, and a steroid, an inhaled corticosteroid. So the other combination of inhalers are listed on your bottom, and those are just other maintenance and um, maintenance and management for COPD patients. Initial pharmacological treatment guide for COPD. So basically, for initial treatment, a patient can be either categorized in group A or B. Group A is basically just your rescue inhaler, a bronchodilator, any of your SABAs, just, quick relief. Group B would possibly add a LABA or a LAMA, a long acting, just for maintenance. The categories for that is 0 to 1 moderate exacerbation, but not leading to a hospitalization admission. Just meaning that, your flare ups kind of got you a little bit out of hand, but with that, they can add an extra medication and then everything should be under control. Um, to be in group E, that would add your bronchodilator, and they would definitely add a LABA and a LAMA together. Um, so that is greater than or equal to two moderate exacerbations, or greater than or equal to leading to one hospitalization. So basically, your COPD is not under control. So then they have to add those extra medications to kind of keep it at bay and keep it manageable and keep you out of the hospitals. I mean, doctors try to keep COPD patients out of hospitals just so that they are not put in that extra risk of catching any other kind of, pulmonary um, diseases such as pneumonia, bronchiectasis, bronchitis. It's a lot that can set back a COPD patient with those type of infections. Um, and then follow-up pharmacological treatment for dyspnea. They can be treated with a LABA or a LAMA. If it persists, they will once again combine that LABA and that LAMA. And then continuing dyspnea, then the physician may consider switching inhaler devices or molecules. They may implement or escalate non-pharmacologic treatment. Consider adding enfer, infiltrine, and then investigate and treat other causes of dyspnea. So they may try to find an underlying issue that maybe is not possibly presenting itself right away, and they're going to do more tests. Um, for exacerbations, uh, for a LABA or a LAMA, it just kind of depends on how high your eosinophil level in your blood is. So if it is under 300, they will add both the LABA and the LAMA. If your blood eosinophils is greater than 300, they will go straight with your LABA and your LAMA and your inhaled corticosteroid. Um, but under all these, you will still have your regular short-acting beta-2 agonist. Um, And then if that continues and persists, they may add more medications, such as a rifamycin, azithromycin, in case there's an infection, making those eosinophils increase. And if they're just constantly increased, then they'll add the dupilumab. Drug categories needed by COPD patients include bronchodilators. Those are your B2 agonists. They include your short acting and long acting. Some drugs in those categories for short acting include levoalbuterol, albuterol, and terbutaline. Long acting is your formoterol, arformoterol, indacaterol, salmeterol. Your anticholinergics, you have two categories, short acting and long acting. Your short acting is ipratropium bromide. Your long acting is tiotropium. Methylxanthines include your aminophylline and your theophylline. Um, Anti-inflammatory drugs include your inhaled glucocorticosteroids, which include your beclomethasone, budesonide, and fluticasone. Your systemic glucocorticosteroids are your prednisone and your methylprednisone, and your phosphodiesterate 4 inhibitors, which are your PD4, are roflumilast.